Okay, hello and good morning to all. Welcome to today's webinar on diverse physiotherapy, osteoporosis, diabetes, and neonates. First, let me introduce myself. I'm Swapnila, moderators for today's session. I'll be responsible for hosting this webinar today. Before we start our webinar, there are some important housekeeping announcements to be made. This session will be recorded by the organizing committee. Please do not record this session on any other devices. Please turn off all the mics and videos. If you have any question for the speakers, later please type them in the chat box during the time when the session speaking is going on. In case of technical issues, please do send an individual private chat message to Ms. Wali directly. At the end of the webinar, you'll be provided with a link to share your feedback. The e-certificates will be sent to you once we receive these feedback forms. So it's very important for you to sign these feedback forms. UTAR students, please note, you have to fill the sign in Google form and sign out Google form for claiming the USSTC points. Both links will be provided in the chat box at the beginning and the end of the webinar. Please enter your names and your emails accurately to avoid any confusion or inconvenience later. And please make sure that you receive your e-certificates within 3 days of completion of this webinar. Okay, if after 3 days, if you have any issues, you don't receive your e-certificates, you can always contact the organizing committee. The emails is already there in the flyer. This webinar is organized by the Physiotherapy Department and the Education Committee, Faculty of Medicine and Health Science, University Tunku Abdul Rahman. Kindly have a look at the webinar schedule details. This is going to be our schedule for today. So please have a look and we will be following this schedule and we will try to execute the things on time and try to finish it on time. So please have a look at the details of the speakers' timings. There will be question and answer session after each speaker finish his session for 10 minutes. So if you have any questions, you can always type in the chat box. So here are our esteemed speakers for today, and they will be sharing their views on the various fields of physiotherapy and health. So this is a reminder for all the instructions, housekeeping instructions. Please make sure that you sign in and sign out the form, and please enter your email and your names correctly. Please make sure that you receive the e-certificate 3 days after the webinar. We're going to start our webinar. So physiotherapy encompasses a wide range of diseases and disabilities, but the goal is to optimize health and to prevent further complications. 3 speakers experienced in the field will be presenting on updates and trends of physiotherapy in osteoporosis, diabetes mellitus, and management of neonates. Please join us for the informative session. So I'm glad to welcome our first speaker, Dr. Karthik Murugesan, all the way from Canada. Thank you, Dr. Karthik. Dr. Karthik will be sharing his views on preventing osteoporosis and osteoporosis complications. Dr. Karthik Murugesan completed his bachelor's degree in physiotherapy and graduated from Annamalai University in 1997. He completed his Doctor of Physical Therapy in Still University, USA. Since 2011 till date, he has been working as a registered physiotherapist in elderly care in Canada, assessing and implementing care plans for appropriate physiotherapy services. In addition to practice, he also poses as a clinical examiner for physiotherapy competency examinations in Canada. So without further ado, now I would like to call Dr. Karthik to take over this presentation.
Thank you. Good morning to Malaysia and from Canada. And I'm really glad to participate in this session. And I treat this one as a great opportunity for me to present my views of experience and the ways to treat patients with osteoporosis. So I'm glad to introduce myself to the management, faculty, and the students of UTAR So today we are going to see about, it is not going to be a very, very formal way of learning. I just want to make it as a great fun activity for you all guys. So we are going to talk about osteoporosis. I know all the physiotherapists and all the physiotherapy students definitely know about osteoporosis, but we are going to go through a quick glance of what the clinical presentation is like for osteoporosis. So can I request to have a first slide, please? I think we have a wrong slide here. I think we have something. The first slide should say what's osteoporosis. I mean, the next one, please. So osteoporosis is a disease characterized by low bone mass and deterioration of bone tissue, which is likely can happen and may not be identified until something really happens to the patient. And we won't even call them as a patient until something happens and the disease was found. So it can be living inside a person. It's not a bug or an organism to live, but what I'm saying is the osteoporosis can present in a person silently without showing any symptoms for years and even decades. So osteoporosis, according to Osteoporosis Canada, it's a silent thief which can be detected when something really happens to the patient. The risk factors for osteoporosis, you can call them as one is a non-modifiable risk factors. Obviously, the gender, that comes first. Females are obviously at more risk for osteoporosis than the male counterparts. And age advancement, and the age goes up due to various reasons. The bone mass can go down and then it can lead to osteoporosis. And the next one, I would say, the important non-modifiable factor is a race, white or Asian accent. Most of the Caucasians are vulnerable for osteoporosis. And then reduced hormone conditions, especially the estrogen. Estrogen is one of the hormone which, when it goes down, obviously it can increase the risk of osteoporosis, especially for the females. And then frail body size. If somebody have very less muscular support for themselves, if they are frail and tiny with small bones, they are at high risk for osteoporosis. And then thyroid abnormalities, especially the hypothyroidism, is one of the common factors which can lead to, it may not be a cause for osteoporosis, however, it can be a risk factor. And the family history of osteoporosis. If somebody has osteoporosis which is running in their families, that can even be a risk factor for an individual. And then history of previous fracture. A previous fracture, even though the remodeling phase is completed, but still it's vulnerable for the changes which can happen in the trabecular system, which is a building block for the bone. So that's the other cause for osteoporosis. Next slide, please. Yeah, and the modifiable factors, if you can see, low calcium or vitamin D intake. Low calcium. Everybody knows calcium can make stronger bones, and vitamin D is the other thing which is really essential for a good trabecular pattern and the strong bone formation, especially for the adults. And then if they are in deficiency, if somebody don't get adequate calcium or vitamin D intake, it is going to put obviously at risk for them to develop osteoporosis. Estrogen deficiency, this is a hormonal factor. And then the lack of exercise. This is an important thing we are going to talk about later, more in detail. Cigarette smoking, tobacco smoking, excessive alcohol intake, use of medications such as steroids, cortisol, glucocorticoids. These kind of medications can make the bone formation. They can delay the bone formation, and sometimes it can move the absorption of the bone tissue faster, but the formation can be kind of compromised easily. And then prolonged use of thyroid hormone. If somebody is in need of the thyroxine, and then if they are administered through some other medications and other stuff, the hormone the excessive intake can even lead to osteoporosis. Osteoporosis can be secondary to decline in bone mineral density following a hip fracture. And anorexia nervosa, which is obviously an eating disorder, which is very common in the athletes, and especially the teenage athletes. And they get into the condition which is called the female athletic triad. This triad is a complex group of diseases. One of them is anorexia nervosa, which people they don't eat at all, and they eat very, very less. It could be so many factors regarding that. It can be even considered as a psychological disease too. So that's the other cause which can lead to osteoporosis in the later part of their life. And then amenorrhea, early menopause, absence of menstrual cycle or early menopause. And then the next thing is chronic liver disease, especially the bilirubin count. If there is a big impact on that, and I would say people with chronic liver disease will most likely get the osteoporosis. It may not be even left undetected, but they are at very high risk. And then metastatic cancer, the cancer which is spread through other parts of the body, especially the lung cancer, the prostate cancer, and the breast cancer, which can get into the bone pretty easy. So they can affect the construction of the whole skeleton, the structure of the bone, and that can lead to osteoporosis. This is the basic factors we just saw, but the devastating effects of osteoporosis, what we called as a cascade effect, because most likely osteoporosis can lead to vertebral fractures. So vertebral fractures can be undetected too. So how the vertebral fracture can happen in a patient with osteoporosis, or if the vertebral fracture is there, if somebody may complain like a dull, achy pain, or even if it's a sharp pain, if they're managing it with some other home remedies or something like that, if it is there, it's like a chronic pain, and if they are managing themselves, and what are the things as a physiotherapist or a clinician, what you have to look for to find out if they have a silent vertebral fracture, which is not very pronouncing. The first thing I will look at loss of height. Loss of height is a first classical sign if somebody has a fracture in the vertebral body. You might be surprised to hear that. When your age goes up, when the posture changes, obviously the loss of height can be evident. It could be in millimeters, it could be in inches, but if you see something which is like close to more than an inch, or I would say 2 centimeters, something like that, you can definitely suspect a vertebral fracture. It doesn't mean they have the vertebral fracture, because if the kyphosis is really bad, if it is getting worse and worse, so the bend which is happening when somebody have a kyphosis, it's going to compromise the height of the patient. So yeah, increased kyphosis, then it leads to decreased balance, and it increases the fall risk. The next thing, yeah, we just saw all this. And then forward displacement of center of gravity. If the center of gravity is compromised. So obviously what happens is when kyphosis happens, the center of gravity moves forward. It will compromise the balance and put that person to high risk for the fall. And variation in the spinal loading and the stress can go to the vertebral bodies in an abnormal manner, so that it will compromise the alignment of the other parts of the body, because one goes wrong, the others has to compensate for that. For example, if there is a thoracic kyphosis happens, then obviously the lumbar lordosis, the normal curvature of the lumbar spine will be lost. Then it's followed by other factors like minor hip flexion, knee flexion, and all those stuff. So obviously, loss of balance and decreased postural control that can increase the risk for fall and fracture. You might be surprised to hear a few facts about osteoporosis. There are two things which are considered as a major things which can put a person if they are osteoporotic or not. So one of that is a T-score. T-score, I don't know, honestly, I don't know the exact abbreviation of that. Maybe you can say it is a trabeculation score. Well, the T-score is a comparison of a person's bone density with that of a healthy 30-year-old person in the same sex. Okay, so for example, if somebody is 60 or 70, it's a comparison of the same sex. If it's a male, then the T-score is a comparison of the trabeculations, which is to the 30-year-old counterpart. That's a T-score. And the Z-score is a comparison of a person's bone density with that of an average person of the same age. So for example, if somebody is like 60, if somebody doesn't have osteoporosis, so they compare the same age person with them, but they both are not, they're close to conclusion, but not exactly. So that's why there are a few other things we need to consider. The T-score, which is anything on minus, they are getting there. For example, if somebody is between -1 and -2.5, then they are osteopenic. Osteopenic in the case, well, somebody's asking, how do you calculate the T-score? It is through the bone scan. If you do a bone scan, it gives a tentative value of the trabecular support, and that's how it is calculated. It is not through any other calculation, but sometimes what they do is they will do a 10% times 10%. The score times 10% will tell exactly how much the bone mass is compromised. The T-score of -2.5 or lower, that means if it is -3, -3.5, that is lower. If it is between -1 and -2.5, then they are osteopenic, which is a predisposing, I mean, not a predisposing. It is, I would say, it's earlier stages or a minimal kind of osteoporosis, you can put it this way. And anything over -1, which is 0, 1, +1, +1 or +2, these things tells you that the bone trabeculations are good and they don't have osteoporosis. And then, yeah, here it is. Multiplying the fact T-score by 10% gives a rough estimate of how much bone density being compromised or lost. And Z-scores, it is just a comparative value, but it is not a definitive value to make a diagnosis. Yeah, so now the common sites of fracture: thoracic and lumbar vertebral compression fractures, femoral neck, distal radius and ulna, surgical neck of humerus. So these fractures are very common. And sometimes this fracture can happen, then they'll be diagnosed with osteoporosis. Sometimes it can be too late to treat those people with osteoporosis at that point. So catching the person with osteoporosis early as possible is necessary for effective treatment and prevent injuries. All right. And then tests and measures. Tests and measures, I want to go through this quickly because I think we are running out of time. Well, how to assess? Well, whom I would suspect a person has osteoporosis. The first criterion I would see is a forward head posture. If somebody throw their head forward, just by putting your head forward, you are using your neck as a bridge, which can add like 25 pounds of weight to the neck region. which is definitely a big stress for your cervical region. So the forward head posture will bring your head forward. And the next thing what happens, it'll be whatever the head does, the rest follows. So a kyphotic posture can happen. So what happens is after that, then you can see the ear lobe is not in right alignment with your shoulder. So it is going forward. So we measure tragus to wall distance. So if somebody is standing at the wall, the distance between the tragus of the ear and the wall, anything over 10 centimeters, anything over 10 centimeters is not normal. So the more lower the number is, the better posture. And then the next thing is we see the height of the person. We talked about that. And then rib and pelvic distance. At the lower end of the rib to the top part of the pelvis, we don't have to go to the anatomical details of that, but it should be at least, you should have at least 2 fingers of width. If you check in the elderly person, I saw a person who was like, I would say 107 years old, probably. She was like less than, I can't even put my 1 finger. I mean, I wouldn't say 1 finger. It could be, I would be exaggerating. It could be a thumb, maybe not even that gap. She was like totally kind of folded. So that distance, the more the distance between the lower rib and the pelvis is better. And then the posture, flexi curve. So it's a moldable curve. What they do is they make the person to stand, and then they put the curve. It is like a plastic, or maybe it's moldable. So they put that in the spinal alignment and see if the thoracic curve and the lumbar curve. And then they put a line between, if this is a thoracic curve, they put a line in there in a paper, and then they will measure the angle. Measure the, not the angle, measure the distance between the line and the maximum amount of the curve which is happening. So that line, the distance should be less than 13 centimeters. So the more the curvature is flat towards the midline, the better the posture is. Okay. And pain, back pain, especially back pain, because they have constant stress going on in the back or the upper thorax. And the range of motion, restricted range of motion, restricted thoracic extension, then lower extremity strength, timed chair stance. So we time them. They have to stand up, the time they take to stand up themselves. And heel raises, how many heel raises they can do, how much they can make themselves tall, raising the heel, which means standing on the tippy toes. And if you say in an anatomical way, standing with your feet plantar flexed, I mean ankle plantar flexed. And trunk, upper extremity strength. And the next one is another important thing, timed loaded standing. So what we'll do, we give like 2 pounds of weight to a person, and they are kind of holding it with their shoulder flexed to 90 degrees. And they have to stand in position. Then they have to hold that position. So 2-pound weights on each hand, straight, hold that for 2 minutes. If somebody can't hold that for 2 minutes, it needs to be documented. If it is 30 seconds, if it is 40 seconds, if it is 15 seconds, it needs to be documented. After physiotherapy for 3 or 6 months, intense physiotherapy, we want to check the values, then it could go up. If they are able to hold the weights for longer, that's a progress. So because if you hold it like that, it's going to check your upper trunk muscles too. The upper thoracic muscles, the muscles, I mean, the scapular stabilizers, everything is going to act together to make that movement possible. Not the movement, I mean, stability possible. All right. And abdominal and back extensor strength, gait and mobility test, timed up and go test. I think you are familiar about that, which is like a time you ask the person to stand up and walk 10 feet, come back and sit down. The normal value for but it will go up if somebody have an injury, if somebody has like compromised balance, fear of falling, so many factors. So the slower they walk, they are at high risk for falls. The slower they walk, it could be due to postural or balance impairment, which is common after osteoporosis. And Berg or Tinati, somebody's asking how many kilos, pounds. Yeah, it's 2 pounds. 2 pounds is 1 kilogram. 2.2 pounds is 1 kilogram. So I would say, I think we used to say kilo, right? So I would say approximately 1 kilogram on each hand. So Berg balance scale or Tinati gait and balance and mobility assessment. So they are all big comprehensive assessments. Even I can talk about Berg balance for half an hour. So these are all the tests which can be done, physically done, to find out or suspicious about osteoporosis. But the confirmatory test, I mean, the definitive diagnosis will be made by doing a bone scan or bone density test. Next slide, please. Sorry, I'm too slow. Well, I try to rush here. Then the next thing is fitness. The basic common understanding about exercise is the mechanical strain with high loads are the best to improve stress on the bone and make them stronger. So resistance exercises should be site specific, and the stimulus must be dynamic, variable, and unique. Well, why we want to stress on unique? Well, you can give a barbell or dumbbell or maybe some resistance bands to somebody and throw it to them and then tell them like, exercises are good for you. It's good for your bone strength. It's good for your muscle strength. So just do them half an hour a day. No, it is not a right way to do when you are working as a physiotherapist. A personal trainer can do that, but not the physiotherapist, because therapy is different. Training is different. Therapy is to cure a problem, let's say, or improve the problem. I mean, improve the symptoms or improve function. Okay, so the stimulus must be dynamic, variable, and unique, and weight-bearing exercises slows the loss. This is another key point, weight-bearing exercises. I have seen a few clients in their 80s. I know a lady who ran her last marathon at the age of 81. A couple of years ago, she passed away at the age of 102. So that means in 1999 or 1998 or somewhere, she completed the whole marathon when she was 81, which was amazing. She didn't have osteoporosis. She didn't have any other problems. But what I'm saying is weight-bearing exercises are the best. What are the weight-bearing exercises? Walking. I would suggest somebody to walk more than I recommend cycling. And some people come to me and say, okay, I was cycling my all day. I was mountain biking all my life. I was swimming all my life. If you compare the T-scores of a person who are doing the swimming all their years and the person who is just walking every day for 10, 20 minutes, the T-scores of the person who is walking will be much better than the person who is swimming or doing something which is not weight-bearing activity. Swimming, rowing, sailing, this kind of stuff. Maybe even surfing, water surfing. Okay, so weight-bearing is a key, and then we're going to talk about that more. Next slide, please. Okay, and the next thing is, prevention. Prevention is better than cure, as all we know. So diet plays an important role. Malnutrition plays a role on poor bone health. So calcium intake is really important. This is a chart, gives an idea of how many milligrams a day every person should consume according to their years of age. The 1 to 3 years, it's like 700 milligrams. And as the age goes up, the need goes up too. After 18, it's kind of standard. If you are 51 and older, you need 1,200 milligrams of calcium. And again, pregnancy, nursing, 18 years. If somebody is pregnant and nursing mother who are 18 or younger, it's 1,300 milligrams. And if somebody is between 19 and 50 years of age, they need 1,000 milligrams of calcium, 1,000 milligrams of calcium a day. And moreover, it should be important. It's like it should be breakdown. It should be broken down throughout the day in the diet, and it should not be consumed all at once, because it's good. It is like you are just throwing it in the drain. It's like you're throwing it in the garbage, because the body can absorb only up to 500 milligrams, if I'm correct, at a time. Most of the people recommend like 400 milligrams or 300 milligrams 3 times a day, something like that. So breaking even is better. Next slide, please. All right, and then the next part, vitamin D. We all know we have plenty of vitamin D available in the sunlight, the natural sunlight. But vitamin D's role is inevitable for bone health. Vitamin D improves your neuromuscular function and reduce falls. The study says there is a solid evidence on the research which was done like 6-7 years ago. They proved that vitamin D deficiency can cause fractures easy. You would be really surprised to see what kind of force can cause a fracture very easy. And hip fractures, especially the femoral neck fractures, for the aged elderly people, even a simple rotation movement, twisting movement can cause a fracture, and then they fall. Most of them break and then fall. We may think that they fell and break their leg, but it can be the other way around. The major culprit here is osteoporosis, loss of bone density. So our vitamin D deficiency can accelerate the loss of strength on the bone. So low vitamin D levels have been significantly correlated with reduced muscle strength, impaired neuromuscular coordination, increased fall risk, and increased body sway. Body sway when they're walking. You might have seen people sometimes they keep a wide base of support, and then they have a little bit of partial sway side to side. They somehow connect the vitamin D for that. The deficiency can cause it. The vitamin D supplementation resulted in 22% reduction of falls, including elderly nursing home participants. Yeah, these researches are based on elderly people, and then all the outcomes are in most of the patients who are close to get there. That means they are walking towards the osteoporotic level of bone density loss. And then well, there were some conflicts on what vitamin D administration. So vitamin D is correlated linked to lower mortality rates. Okay, and the last thing is vitamin D supplementation is not associated with significant adverse effects of any kind. All right, next slide, please. Okay, these are some information about that. Vitamin D is like IU is international units. I don't know what it stands for. International units, I don't know how they quantify it, but it's international units. So adults, 400 to 800 international units, or 50, 800 to 1,000 international units. And the sources of vitamin D, sunlight, when that's important. 50 to 20 minutes of exposure to midday sunshine without use of ultraviolet blocks. Sunscreen lotion is a simple ultraviolet block. UVA blocker, UVB blockers are there, but without the use of UVB sun blockers. UVA is okay. UVB is kind of, if you don't use it, your body kind of tends to absorb more vitamin D. Food, fatty fish, yeah. Fish lovers can consume a lot of fish, salmon, tuna, and then egg yolks. That's important. A lot of people think that the egg whites are better than the yolks. There are so many myths revolving that, even though it is not a dietary subject, but since sometimes we have to give a general education to our patients. So that's why we are touching all this topics. And then if not available adequately in countries like even in Northern Canada, sometimes in the winter, they get 2 hours of sunlight, sometimes no. In Northern Canada, not where I live, but so supplements will be necessary. The vitamin supplements and medications could be necessary. Next slide, please. Okay, and then the musculoskeletal risk factors for kyphosis, spinal extensor muscle strength. If it goes down, you start to hunch. And then spinal extensor muscle volume. How thick is the muscle? How broad is the muscle? So that determines the strength of the muscle too. And then postural stiffness. If somebody is fixed on the posture, I mean, like it could be even habitual. So that will become a stiffness later, and then it can cause trouble. And then trunk position sense. Position sense, that we can talk about that for half an hour anyway, but trunk position sense, all the physiotherapists might know where you are at space, where your trunk is at space. I have seen some senior, in the senior living home, sometimes the senior is lying down and then they say, like, I want to lie down. Well, you're already lying down. It's not their problem. The postural senses, the less awareness of the posture, that could be another factor for musculoskeletal. Somebody asked me, why midday sun? This is very hot. Yes, of course, in Malaysia, not in Canada, I guess. So these studies are based on North America, but I agree some parts of North America, like Texas and Arizona, they're crazy hot. They're 40 plus dry heat. Yes. The midday sun is like, I don't know why, but the research says so. It says the midday sun is more effective or fast in observing UV rays. And there is a study, I remember, I read about that. Morning sun has UVB rays, UVA rays more. And the UVB rays are the midday. So that's why, probably, because they want you to observe more UVB. All right, that's the reason, I think. I'm not 100% sure, I could be wrong even. And trunk motor control, yes, we talked about that. All right, agreed. Okay, and the next slide, please. Okay, total and the exercises, restoring postural alignment. So what we have to focus on, total axial extension. What is the axial extension? It is like you're curving yourself backward. You're arching your back. Simple as that. So that includes dorsal extension. And the next one you might be surprised to hear, it's cervical glide. What is a cervical glide? This is the position where your head can be thrown forward, causing too much stress. So the cervical glide, it is gliding on the top of each other. People may mistake that easily for cervical extension, which can make it obviously worse. So cervical glide, and then abdominal bracing. So obviously the core muscle strength is really important to keep your posture properly. Core strengthening, flexibility, postural awareness, postural control, stabilization activities. Stabilization activities, there are so many stabilization activities you can talk about. A simple stabilization activity could be a core muscle strengthening. Simple sitting without back support, sitting tall and nice, sitting upright. Yes. And application of static positioning and dynamic ADL activities of daily living, or instrumental activities of daily living, and occupational and recreational activities. That's the posture you have to maintain, regardless of whatever the thing you are engaged with. All right, next. Okay, and physical activity and exercise precautions. Avoid high loads through vertebral bodies. That's really important. Overhead presses, I wouldn't recommend them. And anything which is strenuous too much for the vertebral bodies. Then you have to maintain the good upright posture, optimal alignment. We talked about that. Choose appropriate mode, machines, free weights. That's another thing. Well, if somebody is too frail, and if they have a free weight, and if they don't have much control, because the free weights are really hard to control. There is a risk of injury always. There is a risk of strain or sprain. Strain can happen in the muscle, sprain can happen. So you don't want to make anything worse musculoskeletally. So you have to choose or prescribe according to the patient's age and ability and his cognition. And avoid spine flexion. This is important, really important, very important, guys. Spinal flexion can add too much stress on the anterior vertebral bodies, which can lead to compression fractures. So spinal flexion of any kind, people who are at osteoporosis risk, or even people who are above 60s, I wouldn't recommend them. Example, cycling, spinal flexion. It can lead to spinal flexion. Even the sports bikers, sports cycling, they are even worse. They are just fold themselves into half. And avoid forced mid-range loaded trunk rotations. Even some exercises involves your core strengthening or like rotations like that. Even Russian twists, when you do them to strengthen your abdomen, that involves the bad mid trunk rotation. So you got to be, I wouldn't recommend them. And side bending. Side bending, yes, that's an essential movement, but side bending for activities of daily living, or if you're doing it as a strenuous activity, that's different. So we have to be careful on choosing that movement or prescribing that as an exercise. Avoid activities that increase risk for fall. You don't want them to do skipping. You don't want an 80-year-old man to do a skipping. If he can, obviously, yes, why not? But you have to judge. You have to be your own judge before you prescribe something to the patient. But this is overall a risk activity which can lead to a fall. Next slide, please. Multi-component training, 8-month intervention, moderate weight bearing, and multi-component exercise. Multi-component exercises are compound exercises. Compound exercises, it's not targeting to one muscle group. If you can involve more muscle groups which can add stability and protect your bones and joints, examples of those are squats and then push-ups, these kind of things are multi-component. And then improve dynamic balance, chair, stand performance, knee flexion, extension. Yeah, so it's an 8-month intervention of moderate weight bearing and multi-component exercises, which can increase balance, increase the femoral neck bone mass, bone mineral density to 2.8%. It looks like 2.8% is less, but 2.8% is huge. For a person, for a frailing bone, if you can put them back a little bit of mineral on it, 2.8%, which is a huge amount. It can cut down the risk of falls or injuries by, not the falls, injuries by at least 10 to 20%, which is huge. So that's a considerable amount of improvement you can gain through exercises, which is a weight bearing and moderate weight training. And then decrease potential fall risk and fall related injury. There you go. The more stronger muscles, the more stronger bones lead to low risk for falls. Next slide, please. Okay, resistance training recommendations, evidence for increased bone density, bone mineral density as a consequence of weight bearing, impact, and resistive exercise. Applied training principles, specificity, yeah, overloading is important. We are going to talk about that. Overload is nothing but, we all know about 1 repetition maximum. I choose a 1 repetition maximum, choose 80% of weight, and then work in the full range with the right posture. That's simple as that. So then you're gonna train them an ideal trunk and lower extremity body mechanics, plus train for trunk extension steps. Yes, trunk extension, it is gonna improve your axial extension totally, and then improve upright posture, reduce the stress on the vertebral bodies, so low risk for fractures and injuries. So the results will be, with continuing exercises, women can maintain bone mineral density rather than losing the typical 1% per year after menopause. Usually, most of the people with early menopause or after menopause, within 2 years, they lose considerable amount of bone mineral density, but exercises can slow them down quite a bit. But 1% of loss is huge as well. Like 2.8% is, when 1% can put you at risk, the 2.8% gain after exercise is obviously going to do some good for postmenopausal women, not only for them, anybody who is suspicious of osteoporosis. And yeah, 8 to 12 reps. Yes, Borg scale of perceived exertion, I would say they're given a different number here. It's 8 out of 10. That kind of stress level you can go. It's very subjective, but still. So 8 to 12 reps, how do you make it as 8 to 12 reps? That means they should reach failure after 8 reps or maximum to 12 reps. They shouldn't be able to do another movement. That level. And then another thing, guys, don't underestimate our senior citizens. Never underestimate a senior citizen. Just this morning, I saw a lady who is in my nursing home where I work. She's 97 years old, at least doing 4 kilometers a day. 4 kilometers a day with her walker. So never underestimate an elderly person. So they definitely can manage weight training. All right, proper form and spinal.
Dr. Karthik, sorry to interrupt.
Yeah.
The time is up already.
Oh, sorry about that.
Okay. All right.
Okay.
You can continue.
Uh,
Yeah, you can continue and then you can finish it.
yeah, I'm gonna rush through that.
Okay. Thank you.
Sorry, I don't think we have time for demonstration. We can just, at least I have the exercises put down here. So if you can go to the next slide, please. All right, safe exercises, the Pilates, yoga, and Tai Chi. Tai Chi seems to be very effective for improving balance and improving bone mass and improving postural control. But yoga and Pilates, you have to be careful about rotational movements, trunk flexion, any abnormal stresses which can promote twisting of the spine has to be avoided. I think we're running out of time, so I'm sorry we have to rush through here. Can we go to the next one? All right, balance and fall prevention, improve balance, gait parameters, fall risk decrease due to improved postural control. Yeah, already we talked about Tai Chi. Exercises preferably in standing. Kyphosis, that means you're bringing yourself up. You're doing a tippy toe standing, and then you're going to lower your heel down and the calf rises. So you have to feel the squeeze of the calf muscle. Then that's when you're done, and then you can slowly lower yourself down. And marching in place, that's a very good exercise. Half squats, not a full squat, half squat. The form of the half squat is really important. When they do the squat, they shouldn't be let the knees pass their toes in the front. That's very important. And then hip extensions, hip abduction without weights, because that's going to put too much stress on the femoral neck. So we have to be really careful on that. And sometimes abduction with the weights can cause rotation, and it can increase the stress going on to the femoral neck. Next slide, please. All right, and the postural exercises, chin tucks, I'm going to show you in sitting. Chin tuck, it's not an extension. It is like as if like you're pulling your head back and putting it on the top of the shoulder. Because when these muscles are not activated, a lot of people after 60s or 70s, you could see they are walking like that. Because when they put the head forward, the shoulders are going to tip forward, and the shoulder blades are going to tip forward as well. And then they develop the kyphosis, and then the lumbar lordosis will be lost. And the next thing is they develop tightness in the pec muscles. So that's why the alternate arm lifts. Alternate arm lifts is not just 180 degrees. You have to go all the way back. We ask them to stand at the wall and ask them to touch the back of the hand. The dorsum of the hand should touch the wall. And they should do it very slowly. Even you can try that by yourself. After 5 or 6 movements, you will understand what I mean, because it's going to needs a lot of effort for the elderly portion to do it. And then shoulder bracing, just keep the arms here in the middle. And then you're going to pull your shoulder blades back and then squeeze your shoulder blades and let go. This is an important movement. And slowly, once they feel easier, you can give them a TheraBand, the exercise bands, to add more resistance. This is one of the awesome exercises they can do. And then thoracic extension using a foam roll. I thought of showing that, but we are running out of time. A foam roll is a piece of foam which you can put back, and then you can facilitate extension lying on the top of it in supine. Thoracic and lumbar extension in prone. Yeah, put a pillow under the abdomen, and then it's a Superman pose. If anybody knows about Superman, everybody knows about Superman, I guess. That's a Superman pose with the arms out. Extend your back and hold your head, not hyperextend. That's really important. So these are the postural correction exercises. How you manage it: strengthening exercises, pick exercises 2 to 3 times a week, balance training 2 to 3 times a week. I would suggest walking every day for 15 minutes with the right posture, and then posture correction exercises at least twice a day. I'm too fast here. I'm sorry, because I spend a lot of time on explaining the other stuff. Can we go to the next one, please? All right, resistance exercise, again, 70 to 80% of 1 arm. 1 repetition maximum, pick 70 to 80%. Avoid overhead presses, flexion and twisting of the spine. That's really important. We should avoid those things. I wouldn't ask them to put the weights down from the floor. I wouldn't ask them to pick up the weights from the floor, pick up from the rack. And you have to get close when you put the weights down on the rack. That's really important, because when they bend down to pick up the weight, it's going to add too much stress. Wall push-ups, one awesome exercise. Chair push-ups is nothing but you can put your hands on the armrest and lift yourself up, pressing down and lifting yourself up. That's called chair push-up. Half squats with weights like a medicine ball or something. You don't want them to hold it up. You don't want them to hold a barbell or something which can compromise their balance. Give them the weight. They can hold it right here close to the chest, and they can do the squats. Even without weights, they can start. All right, lunges should be done very safely. Anything with thoracic flexion should be strongly discouraged. And then the posture correction of the form is really important. That's where the physiotherapist role plays a vital part in progressing their disease. All right, walking as a habitual exercise is insufficient stimulus to impact bone mineral density. This is when you have to be, it should be more impactful. The walk, instead of walking, it should be a fast walking. It's not be a leisure walking or something like that. Weighted walking, maybe 3 or 4 3 pounds of weight, put it in a backpack, put it here. It will promote weighted waist, weighted vest, or a weight on the bag, and then they use it as a backpack, and then they can walk with it. It's going to add more resisted walking. It's going to improve the strength as well. Sorry, I'm stammering because I'm rushing through. All right, and then long-term use of weighted weights shown to prevent hip bone loss in postmenopausal women. Yes, positive effect on posture and back extensor strength. All right, next please. Okay, the do's and don'ts on leisure, supine extension exercises. Sorry, it says supine, but it is actually spinal extension exercise. Deep breathing exercises, spinal stabilization, regular weight bearing exercises, regular strength training, balance and agility workouts. And do not do jumping, jarring, because jumping put them at risk, otherwise risk for fall. Otherwise, a controlled jumping is a good exercise. Resistive flexion or torso twisting, resistive hip adduction or abduction, I would avoid both of them. From sitting to standing. Resisted abduction and adduction in sitting or standing, not sitting to standing, or from sitting. It's in sitting or standing. Any activity which increases risk for fall, obviously it's a big don't. All right, so I thought of showing some exercises, but we don't have time for that. Let's take any questions if somebody have, because this is a 3-day hands-on course. I was trying to put them all together in 45 minutes, which may not be a good idea, but we tried our best, I guess.
Thank you very much, Dr. Karthik, for the excellent presentation. I'm sure our participants have enjoyed this informative session. Now, Dr. Karthik will answer some questions that were sent to us during the session. So the first question is for you, Dr. Karthik. Other than walking, what kind of exercises we can do?
Yeah, quadruped exercises within all fours. With all fours, they can do the hip extension. You know the quadruped position, right? It's like you'll be on all fours, and then you're doing the hip extension. You can do the, one arm lifts and one alternate arm and leg lifts on the sides and hold that position for stability. These things can simultaneously improve the balance as well as the posture. Hello?
Okay.
Are you there?
Right. Thank you, Dr. Karthik. We have another question for you. When we should start checking for osteoporosis? Do you recommend it to be done like an annual blood test?
Well, I would say there are some red flags. Doesn't matter, you might be surprised. Sometimes it can be necessary for a person who is 21 years old, believe it or not. Somebody have a poor dietary practice, like when we talked about the female athlete triad or something like that happens, or if somebody has fractures, the red flags, like if somebody have a history of wrist fracture or a motor vehicle accident which caused a fracture on their neck, or even what I would say, it's if there is a fracture, especially like a bone, both bone fractures, or a hip fracture, which has happened in 50s or 60s, that could be a important thing to note for osteoporosis. But what I would say, anybody over 51 years of age, yes, it's a good idea to have check for osteoporosis. I mean, the bone density test would be the right option to do. Not every year, I would say. They can be done every 2 or 3 years.
Okay.
I hope I answered your question.
Yes, yes, yes.
Okay,
We have another question for you. Okay.
sure.
Regarding the T scores and the Z scores, are the
Yes.
normative values the same throughout the globe? Or is it same for the Caucasians compared to the Asians?
Yeah, density remains the same for bone. It's I think people can easily mistake the mass of the bone. I mean, the overall size of the bone and the building blocks of the bone. The trabeculation, which is the interior part of the bone, is the same regardless of how bigger the bones are. It could be even for different races like Mongoloids or African Americans or Asian or Caucasians. Even though their bone mass is different, the bone mineral density is the same. The values are really the same. The minus 2.5 is pretty much standard for diagnosis of osteoporosis. Yes.
Okay, so the bony structure doesn't matter. Even the height, frame, and on it doesn't matter. It is only
Well,
the
thin flail look. If somebody is very frail, if somebody have a thin bone, it could be an abnormality, but it doesn't mean if somebody is naturally, like by racially they are thin or thin built. That's the difference between strong and thin. There's a difference between a frail bone and a thin bone. So frail bone is different. You can see them weaker, less muscular support and all the stuff. And they might have even hypermobility. If you see some women, they might have, if you see the hyperextension too much that for elbow, if somebody have hyper flexibility, they may see that as an advantage, but do not confuse them with the gymnastics. That's different. But the frail and thin bones are more susceptible for osteoporosis, but the bone mass is the same normal value regardless of the bone mass.
Okay, doctor. I will take one more last question for you. Does young adults easily get osteoporosis? Like if someone have poor diet or sedentary lifestyle?
100%. If they have poor calcium intake, it starts with too much of body conscious, especially it's on the teenagers, on teenage females. They want to, for some reason, if they are in gymnastics, they are in ballet, or if they do something which they are desperate to show themselves very thin, then they beat themselves up with poor habits. I have seen 3 patients with anorexia nervosa. It's not fun to deal with. A lot of psychology involved in that. They have multiple specialization consultations. It is very stressful for them and the family too. So those people, those things are the red flags for diagnosis, early diagnosis of osteoporosis.
Especially very common nowadays because of today's generation, sedentary lifestyle and the pandemic and maybe the incidence is
Yeah,
rising a lot.
sure. And lack of exercise is another primary reason. For example, I can tell you there are 35 million Canadians. I mean, 35 million is the Canadian population, 35 to 37 million. Among them, 2 million every year affected with osteoporosis, approximately, in the adult population. So it is pretty prevalent. Obviously, throughout the world, that's why it's a silent disease. When the fracture happens, when somebody, it can change their life, and then it could be even a cause for death. I have seen so many bad fractures and death following that. Well, osteoporosis is the one has to be taken very seriously. Yes.
Okay, thank you, Dr. Karthik, for answering those questions and for the great presentation. It was such a pleasure having you with us. Thank you for your great
Thanks.
question.
I don't think it's a great presentation because I was too slow.
Okay, thank you very much.
You're very welcome. You have a good day.
Okay.
Thank you all the students and the faculty of UTAR. Thanks for having me. It's a great opportunity and pleasure to have you all. I hope to meet you soon again in another session. Thank you.
So before we go to the next session, there is a gentle reminder on the housekeeping announcements. UTAR staff and students, please fill in the attendance on the sign-in forms. The feedback form will be closed 3 hours from the end of this webinar. and any email pertaining to the e-certificate of participants will only be entertained 3 days after the webinar. Any email sent later, that means after the 3 days, will not be entertained. Thank you. So now we proceed to our second session. We're eagerly waiting for our second speaker. I'm glad to welcome Dr. Ilayaraja Alagya Tiruvavendikam, who will share his thoughts about physiotherapy, helping you keep the diabetes away. Let me give a brief biography of our speaker. Dr. Ilayaraja has completed his PhD in 2018 and completed his Master's in Physiotherapy, Cardiopulmonary Science in 2003 and Sports Physiotherapy in year 2000. His research interests include sports rehab, cardiorespiratory fitness rehabilitation, diabetes management, and practice of dry needling. Dr. Ilayaraja is experienced in the education arena, spanning the globe from India to the Middle East. Currently, in addition to lecturing physiotherapy in Uttar, he is also involved in quality assurance and research development. Now let's call our esteemed speaker, Dr. Ilayaraja, to take over this session. Dr. Ilayaraja.
Yeah, good afternoon, everyone. Thank you very much, Madam Sapinga, for a wonderful introduction. Okay, the topic assigned me is in helping you keep diabetes away. So physiotherapy, how it will be works and how far it will be helps the people with the diabetic complication, and how far it will be works to get a benefit of doing the program or the protocol. I would like to go with the basic information because a lot of different communities are working, attending the program here. So we'll look to go for basic information first about the diabetes mellitus. It is a kind of metabolic disease which will be used to get the increase of the blood glucose level. The insulin is the hormone which is mainly responsible and produced from the beta cell of the pancreas, which is mainly regulate and maintain your blood glucose level. Have got the three types of diabetes used to be checked: type 1 diabetic, type 2, as well as the gestational diabetes. The type 1 diabetes, there will be an insulin deficiency. It won't be produced of your much insulin by your body. Usually it will comes under the category of type 1. Whereas the insulin resistance, the body doesn't absorb properly of the insulin. That will be the case where you can see for the type 2 diabetic. Whereas the gestational diabetic is the one where during time of pregnancy used to be carried out. This is also again the absorption problem in the cells. Let's see about the difference between of the type 1 and type 2 diabetes. The type 1, it will be the cause for to get the type 1 is due to a genetic factor, a gene factor. And the type 2 is the one where used to be get off, you don't have an, symptoms you usually see until it will be arise for the person. When you see the type 1, it will be used to be occur in a short time of period, within very typically with a severe, within a week time, it used to be carried out. Whereas the type 2, it will be used to be get until you get off your complication, you may not know that. Sometimes even for a 10 years of period, the person doesn't know whether they have got the diabetic. It will be take some progress to occur, and it takes some several years to occur and show the symptoms as well. Okay, let's see the basic information of the statistic part in Malaysia about the diabetes mellitus. Almost 7 million Malaysians aged 18 years and older are estimated to have the diabetes in the year of 2025. That is the main concern supposed to be take and work out for a lot of activity to prevent of getting the diabetic. When you see the statistics of 2013 and 2019, according to the National Diabetes Registry of Malaysia, it shows that Selangor is the state have got the highest number of diabetes in the country, followed by Johor and then Perak. You can see that 1 in 5 adults in Malaysia have diabetes. So wondering, you have to check about the ratio here, 1:5 in adults in Malaysia. You can see the statistics part here. Almost the Selangor has the highest number, it shows, according to the 2019 diabetes registry. And you can see the things over here. The age group which is affected in the particular time or the particular age group, I can say it is around 50 to 54 is the age group mainly got more affected in the diabetic, and followed by 55 to 59 age group, and then followed by 45 to 49 is the age group mainly got affected by type 2 diabetes. When you check about the ethnicity of the patient in Malaysia, you can see that there will be a huge amount of population belongs to Malay it get affected. It's got the highest percentage. We can say that it will be around 59.15% of the patient consists of the Malay got affected with the diabetic, followed by Chinese community got 19.62%, and then followed by an Indian community at about 13.7%, and the others with the 8.05%. This is what the ethnicity group which was get affected by a diabetic according to the registry. Okay, let's see about some of the symptoms of the diabetes. The basic symptoms, you can say that there will be 3 P's you have to remember. Whenever you got any one P, you have to be careful to go for diagnosing, or you can go for a diagnostic test to confirm whether you got a diabetic or not. What are they? Polydipsia, polyuria, and then polyphagia. So what is the polydipsia? Is an excessive thirst. So excessive thirst, which usually occurs, it will be whenever the high glucose level which is present, it may lead to get of your dehydration in your body. Shows that there will be an excessive or getting a symptom of excessive thirst. The excessive, frequent urination, the polyuria is the one where it will be say that it is a frequent urination. How it will be happen? What is the basic concept here? The kidney, which is used to excrete a lot of glucose, which is present in our body through an urine, sometimes along with the digging with tissues as well, which makes to get off your dehydration as well. So absorb the excess glucose, which is going to be, it cannot be kept out by the kidney, makes to create or excrete through the urine. So other than that, the polyphagia is the feeling very hunger. So most of the glucose which is utilized or not getting into the cells where it is needed. So glucose cannot be able to enter into the particular cell. So body cannot be able to convert your food into energy. So during the time, the lack of energy may cause to get off your repeated, the increase of your hunger. So 3 things are very important symptoms that have to be noted out at the time when you have any of the symptom among this. Other than that, lethargic, unintentional weight loss will be there, blurring vision, increased risk of infection, and then irritability, mood changes, and then cuts and sores might be doesn't have your proper healing over there due to poor circulation. So these are the things can be see as a symptom of diabetics. So whenever you got any one of the symptoms, you have to be carefully identify and have to be go for a glucose test for to identify the diabetic. Okay, what can make my blood sugar rise? So this is the question. Can we say that whenever the blood glucose rise, it will be say the term, it will be say that it is a hyperglycemia. It's a technical term used to be say that. Whenever it is not treated properly, it makes to get off your damage of the blood vessels. Whenever it makes to damage of your blood vessels, small blood vessels, it makes to get off all the complications in the later part. The eyes, kidney, so everything is going to be get affected. The function is going to be get altered. And what are the causes for getting this hyperglycemic? The dehydration, the patient, the person who is not very being active, physically not active, doesn't have your proper enough insulin, and side effect, which is by the medicine, and illness, any kind of stress, or short or long term of pain, which may menstrual periods, all the time, it makes to get increase of your hyperglycemic. Okay, what can make my blood sugar fall? So this is the case where you can see there is hypoglycemia. The term used to be said that hypoglycemia is the low level of your blood sugar level. It will be used to be show that it will be a 70 milligrams per deciliter. That is 70, lower than that. So here some of the causes for getting this, hypoglycemic. They are not enough food, or missing a meal at the time, or alcohol, especially on empty stomach, too much insulin, or side effect, or no physical activity. When it makes to participate in a more physical activity or vigorous kind of activity, which makes to reduce of your blood sugar level as well because of the more utilization. Let's see about this hyperglycemia and hypoglycemia. I have got all these symptoms. Whenever the patient has got hyperglycemic, there will be an excessive thirst and urination will be there, and without a glucose. So if the properly, without a glucose in our body, that it makes to get lead to get off your ketoacidosis. The ketoacidosis is the one where it makes to get off the symptoms like the breathing, a fruity smell, or nausea, vomiting. And if it is a case it doesn't treat it properly, it makes to get off the coma stage as well. Hypoglycemic, there will be a dizziness. Usually a sudden symptom that you can be find is a dizziness. You can be find for a case of the hypoglycemic people with the sweating, then rapid heartbeat, and then headaches, sometimes the tingling also it will be there. That is a symptom that you can be find out when the patient has got the hypoglycemic. These are all the general information about the symptoms which is used to be occur at the time of hyperglycemic and hypoglycemic. And who are all the person need to be go for a diabetic testing? Whenever the patient have a family history, they must be very alert and they have to be go for doing the diabetic testing. And when the person have got personal history of abnormal blood sugar level, and the person who is sedentary lifestyle, who is following within a sedentary lifestyle, who is not participating in a particular the regular physical activity, and the person have got the other conditions, have like blood pressure, high blood pressure, high triglycerides, low HDL, cholesterol, in the sense high actually supposed to be low HDL cholesterol, and then all the heart diseases if they have got. So all those condition if they have got, so they may be ready to check for the sugar level as well to see that any risk factor for getting the diabetic. And why it is required? What is the requirement of the check for the routine blood sugar level? Routine blood sugar level, when you check, you can be easy to identify that whether the person have got, or the person have got low or the high level of your blood sugar in your body, either hypo or hyper. It can be that either hypo or hyper, in the sense like a low or high level of your blood sugar. Why we have to identify these two? Whenever if it is not treated properly, whenever the blood sugar level is not in control, that it makes you give out a lot of furthermore complications as well. So all the time you have to check the level of your blood sugar. Can be used to have like blood glucose log or the diary you can be maintained to see that weekly or monthly. That will be helpful to identify the level of your blood glucose in your body. You should not be we should not be allow the blood sugar level to be go high or should not be go less as well. So all the time it will be the routine check is very important. If the patient the patient is diagnosed as a diabetic, they must be go through with this routine blood sugar level check also to avoid of your complications, diabetic complications. Regular checks, yes, of course, even for a normal popular or the normal person, you can be go for every 3 months you can be checked of your blood sugar level. Whether they have got either is a normal person as well as the those who are diagnosed already as a diabetic, they can be go for every 3 months. They have to check about the blood sugar level, how it is, whether it will be goes in abnormal, the range that you have to be checked it out. And once in a year, everyone or the one suspected to be from the pre-diabetic, the person maybe they can be go for checking of the feet and eyes have got any changes they have performed. So that has to be go through every once in a year. And once in a year, it's supposed to be go through feet and eyes to see that any of course, we can say that any kind of loss of feeling or either numbness or the pain or tingling over the periphery part that you have to be checked out. Along with that, you have regular check with the blood pressure, cholesterol, and kidney also have to be checked to prevent of getting of the the future heart attack or the stroke for a person. What is the range of blood glucose? So you can see that the type 1 diabetic before meal it must be go through it must be have 4 to 7 millimole per liter. Then if it is a case of adult type 1 diabetic, must be have the before meal, it must be the normal range they mentioned here as an overall stat. It will be sure that it will be in the normal range, how it will be 5 to 7 millimole per liter. And when the patient has got type 2 diabetic, 4 to 7 millimole per liter before meal. And if it is a case of gestational diabetes, there must be go through with the fasting glucose level must be have below than 5.3. This is the one usually check for a range supposed to be. Okay, this is the area where how to prevent and manage the diabetics. So the type 1 diabetics, not possible to prevent, only to control. Whereas the type 2 diabetes, you can be prevent of further complication and control your, the sugar level as well. So how it is? What are the way you can be go through? First thing, you have to check about the normal weight, in the sense like the body weight has to be checked all the time. Whenever you are not in the normal range of 18.5 to 24.9, then it will be become like if it is more than 24.9, then you have to be say that it will becomes under the category of the weight, in the sense overweight category. So the obesity, how it will be get of your diabetic. So obesity due to accumulation of fatty acid as well as the inflammatory response make to resist your insulin, which is absorbed in your body. So that makes to produce of a lot of glucose level in your body, lead to get off your risk factor to get off your type 2 diabetic. So first thing, your obesity have to be identified, and you have to be work out for a physical activity. The physical activity minimum of 30 minutes of regular moderate intensity activity is supposed to be go through. And healthy diet is very important to make avoiding of sugar and saturated fats intake, and then alcohol has to be avoided. Alcohol, tobacco, smoking. Smoking also one of the main risk factor for getting of your diabetes and cardiovascular diseases. That should be avoided. So this is the way you can be the basic component. We can be say I can be say that this is the way you can prevent of getting your further complication for a type 2 diabetics, or the person who has got already the pre-diabetic, in the range of pre-diabetic, they can be prevent of getting the type 2 diabetic in the future by following all these activity of physical activity, as well as maintaining your body weight, as well as taking up your proper diet and avoid of the tobacco use. Okay, let's go to the basic point of the PT assessment for a diabetic. So what are the things supposed to be do for a screening? The pre-participation screening is very important for a diabetic patient to assess by a physiotherapist. What are they? General medical risks have to be identified by using of the PART questionnaire. That is the one where it can be used to get of your health and lifestyle component can be easy to be identified by using of this PART questionnaire, physical activity readiness questionnaire. And then the specific medical risk, like which is related with the neurological, cardiorespiratory, nephropathy, and then retinopathy. All the medical risk component supposed to be analyzed and get the information of all the investigations, what they've done before. And all the time you have to be get the lab values of the glycemic control and the health parameters. You have to be go through for doing all the muscle strength, and then endurance exercise capacity have to be identified, because it is very important to prescribe of your exercise program for the patient, those who are affected with the diabetic. And then body composition have to be measured properly, and physical activity level can be identified by using of the meter or the accelerometer to identify of your distance and time, the calories which they burn. And fall risk also can be identified by using of the time up and go test and dynamic gait index. So the one which will be useful for to identify with the activity how far the patient balance can be maintained. So all these things has to be used for pre-participation screening must be go through for diabetic people. This is the first step. supposed to be the step 2 to identify that how far the during the time of exercise training, what are the things supposed to be keep in mind. Supposed to be check the glycemic control all the time before and after an exercise. And cardiovascular safety, you have to be checked about the resting heart rate, whether the person has got the resting heart rate in the range of 60 to 100 beats per minute. And then blood pressure, also a vital, supposed to be important to check all the time before and during and after. And the retinopathy, suppose the patient has got any other complication, the diabetic person with have got any other complication like retinopathy, nephropathy, peripheral neuropathy, and autonomic neuropathy, all these have got any other complication along with that, then you have to be carefully monitor the intensity which you are going to be provide for the patient, or which you are going to be give for the patient to do of the exercise program. So you have to avoid of certain activities, certain exercise program, and that's going to be seen in the furthermore slides in detail, how far the particular diabetic complication, what are the kind of exercise program you can be assigned for the particular individual. Let's see about that later. And here, during the intervention program is a general, I just giving you about the general idea about the intervention program, which is required to go for diabetic people when you prescribe any kind of exercise program. The FIT principle is supposed to be used. The FIT is the frequency, the number of days per week supposed to be worked for diabetic people to participate in a particular physical activity. And the intensity, whether going to be prescribed a low or moderate or vigorous kind of activity is performed by the person, that have to be decided. And then the time, how many minutes per session of your endurance program you are going to be assigned for a particular individual. And then the type, either it will be belongs to the category of endurance or the strength or flexibility or the combination of all. So that have to be decided. So all these have to be keep in mind, all the FIT principle, according to the FIT principle, you have to prescribe the exercise program for a diabetic. Basically, they used to prescribe, or the one you can be say 3 to 5 days of exercise per week is ideal to perform or ideal to be prescribed for diabetic people. They have to be concentrated on 4 things, mainly strength, endurance, and then go through foreign stretching as well as the coordination activity. These are the 4 things definitely have to be keep in mind to prescribe the exercise program for a diabetic. And of course, you have to go through with low to moderate endurance exercise. You have, before going to prescribe the exercise program, you must be go through to identify the exercise endurance of the patient. So exercise capacity has to be identified, followed by you can prescribe of endurance exercise program with the intensity according to the the person individual capacity. You have to be go through of prescribing either 50 to 75% of the intensity you can prescribe. So maximum of 150 minutes per week is the ideal program or the physical activity supposed to be given for an individual, those who are affected. And strength exercise modality have to be go through for 5 to 10 exercise per session of 3 series per exercises and 10 to 15 repetition supposed to be go for that. And you have to be when give off your kind of exercise program, when you make it to give off your any kind of endurance exercise program or aerobic kind of activities, you have to keep in mind that the base exercise intensity have to be base exercise intensity on heart rate reserve has to be calculated before giving out the program. So according to the Karonen method, you can be prescribed the according to the Karonen formula, you have to find out what is the maximum intensity program or the maximum the heart rate maximum you can allow the person to perform to do on participating in your physical activity. That you have to be used the formula to find out. According to that, you have to go through. Suppose if the case of 75% of the maximum intensity you want to perform, then you have to accordingly you have to calculate the resting heart rate, and then you have to multiply by a maximum intensity plus with the age, then you will be getting up the maximum of beat per minute you can be allowed the person to be performed of the particular exercise program. So that is the way you have to go through with that point. What is the thing you have to do before exercises for a diabetic? What are the things supposed to be considered? If the person, you can see here, monitor the blood sugar level, the glycemic level are supposed to be identified. What is the glycemic level supposed to be identified, and what is the thing you have to be go through? the patient, you have to observe the dehydration and tiredness of a person. If the dehydration felt, then the person should be allowed to go for taking plenty of water. If the person has got any, the glycemic blood sugar level shows that it will be a 5 millimole per liter, then you have to take, you can make the patient to eat or drink 10 to 20 gram of carbohydrate. If it is, between of 5 to 8 ml, you can make them to go for another 10 gram of carbohydrate. And if it is a case of, 8 to 15 millimole per liter, you can allow them to start doing of your exercise program. So if it is less than the 80 millimole per liter, you have to make the person to take off, any kind of carbohydrate. So I can be say one example, like the bread is the, one bread, sliced bread, it will be the one where it will be contains of 30 gram actually supposed to be, but you have to imagine how much you have to be, need to be consumed, given for the person or make the person to be eat. I can give some example over here, like any one orange or apple or star fruit or pear, it will be contains of, the 15 gram of it's 15 grams. So you can be say that that is the one that they can be make it out to eat and before participating in any exercise program. So that is the one we have to make it out. And suppose why we have to consider this glucose level, why it is important during the time of exercise program. See, all the time, whenever the person is participating in any exercise program, it makes to reduce of your blood sugar level. It makes to increase of your insulin sensitivity, which makes to reduce of your lower your blood sugar. So whenever there will be lower blood sugar, then hypoglycemic used to be get with all the symptoms. To avoid of all the complication, you must be analyze your glucose level during the time of your exercise before going to participate in an exercise program. If suppose the person has got hypoglycemic during the time of physical activity, so what is the thing, or before going to participate in the physical activity, if they found that there will be a hypoglycemic, what is the thing supposed to be do? You have to check again the glycemic level, how it is, 100 mg per dilution or lower. If it is lower than this level, the person has to be taken out the 15 to 20 gram of carbohydrate. This is actually, can we say that it is in 15-15 rule, according to the American Diabetes Association. It will be says that it's 15-15 rule. What is the 15-15 rule? Is 15 grams of carbohydrate have to be consumed by the person, and you have to wait for another 15 minutes. Still, the blood sugar level shows that less than 100 mg per dilution. Then again, you have to serve another 15 gram of carbohydrate. Repeat this step every 15 minutes until your blood glucose level comes into the range of 100 mg per dilution. So once it is, make sure it will be comes back into the normal range, then you can make the person to be start doing of the exercise program. Or even before exercise, you have to check at the same time during the exercise they found there will be a low, then you have to make it out all these changes as well. Okay, let's have a question here. Is that exercise is helpful for a diabetic? Yes, definitely it will be very helpful for a diabetic person. It will be very helpful to reduce of the weight, and it will be reduce your risk of heart attack as well as the stroke, and overall health is going to be promoted by doing of your physical activity and prevent of getting and developing of your type 2 diabetic if the person has got the pre-diabetic. So what is the range we can say it is in a pre-diabetic? If the range, if it is comes under fasting plasma glucose level, it comes under the range of 5.5 to 7 millimole per liter, or the oral glucose tolerance test, it shows that 7.8 to 11, it comes under the category of pre-diabetic. The pre-diabetic people are the more risk factor for getting your diabetics in the later stage. So they must be gone through with this, all these exercise program can prevent of getting type 2 diabetic in the later stage. Okay, should exercise daily for a diabetic? This is the next question here. Yes, the person those who are affected or the diabetic supposed to be follow weekly 5 days, supposed to be participate in moderate to vigorous activity. That will be more helpful for getting you for the complication. And 2 days of time they can be followed with the resistant exercise program. So or the mix up with resistant exercise and aerobic exercise. That will be the best way to control your glycemic level in your body. So that is the one they have to be go through. So physically active every day, and you should not be made to be take off 2 days, meaning 2 consecutive days. That is the one you have to keep in mind. So all the time you have to ready to do of your activity with the mix up of aerobic as well as the resistance exercise program. That will be the getting of your more benefit. I'm going to show the evidence which is getting of this, like the supporting for this, the physical activity. How did you make to injury free foreign diabetic people while participating in the exercise program? All the time they have to be carefully inspect their feet, and activities should not be over, or should not be prescribed to go for more vigorous activity to participate. The energy level should be according to their capacity. You have to prescribe. You should not be make them to participate or make them to utilize of doing the activity like a vigorous kind of activities. Have to be go through with moderate kind of activity is beneficial for a person with will be giving of your good benefit you're going to be attained. All the time they must be wear the medical tag, and all the time they have to carry the carbohydrate and sports drink whenever they felt the energy level, or they found that there will be an hypoglycemic, they must be take up any carbohydrate to level their blood sugar level. Drink plenty of water to avoid of getting dehydration, and the person should not be participate any kind of activity in the hot or cold temperature. The patient already have got is the dehydration usually to be the one of the symptom for a diabetic. If they participate in that particular the temperature, it makes to get off your more, it makes to get or more to prone to get off your more dehydration as well. And before going to participate, they must be go through for warm-up exercise for 5 minutes of time, and the cool down period after doing of your exercise program, they must be go through for a cool down exercise as well for 5 minutes of time. That will be makes to get off further complication for a diabetic to maintain their length of their muscle as well as the joint flexibility. What are the benefits of doing the exercise program for a diabetic? Whenever the person is participating in the exercise program or the physical activity, that will be mainly increasing the insulin sensitivity, and also you can see that the joint and flexibility is going to be maintained properly. They're going to be lose the weight, and the sense like the obesity. Suppose the person with an obesity, they're going to be lose the weight, and they're making to be the BMI to be in the normal range. That will be the one of the main benefit that's going to be do when they participate in the exercise program. And it's going to be control of the blood pressure as well as the cholesterol, because all these are the component where next to get off your more diabetic complication as well. So these are the things, the benefit you're going to be attained of all these things when they participate in the physical activity. What are the general benefit health or general health benefit which they're going to be attained by doing of your exercise program? Generally, you can see here the 50% of your risk of your type 2 diabetes is going to be reduced by making the person to be participating in exercise program. And you see that here 83% of the risk of osteoarthritis is going to be get reduced by participating in the exercise program, and the risk fall is also going to be get reduced up to 30%. So these are the general benefit, and then moreover when you relate it with the diabetes, you can see that more amount of percentage have got benefited by doing of your exercise program. So that is what insisting to go exercise program must be there for diabetic people. Okay, some of the evidences are there to support for the exercise program for diabetic and exercise. What are the exercise program that they can be go for?
Sorry, doctor.
Yeah.
Sorry, Dr. Raja, to interrupt. Actually, time is up. Yeah.
Yeah. Okay. Let me go through quickly. Okay, I'll show some of the evidence here. During this pandemic time, the diabetic mellitus, yes, the more risk for at the time of the person within diabetic have got more increase of the risk due to COVID-19 during this time. So they need to be very much have to be very careful. Carefully, they have to monitor all the glycemic level as well as all the the routine eye checkup. All these things will be required for a person with a diabetic, and they can be participate in all the community rehabilitation program or the group education program. Tele-rehabilitation they can be attend to get off the a lot of tips and a lot of advices from the health experts. So that will be the way. The self-education and self-management is the main part that they have to be taken part, or they have to make it out to reduce of all the complication as well. So they have to be checked with this self-education and self-management supposed to be participate, or in the sense like they have to be get with all the information on how to manage their diabetic by themselves. That is the only way to reduce of your risk during the time of pandemic COVID-19. And according to the American College of Sports Medicine diabetic care, the article says that physical activity participation for a person, for a diabetic with the type 2 diabetic, they can be prevent on delay of the chronic complication of a diabetic. What is the thing here? What is the point mentioned here is that glucose uptake is more going to be consumed by an active muscle. So that makes to that makes to greater reliance on the carbohydrate to fuel muscular activity as intensity of the exercises increases. That is what the the evidence shows here. And this is the another the evidence saying that aerobic exercises is best way to reduce of your arterial stiffness and other further cardiovascular complications in type 2 diabetes mellitus. And the resistance training for a diabetic, you can be use of the free weight and resistance band training within 60% of the maximum. It will be helpful for to control your blood fasting percentage and blood lipids. And then combined effect of this is another the evidence saying that it's a RCT, randomized control trial, showing that resistance program plus our aerobic training, both is getting the benefit of getting your increasing of the aerobic endurance of a person, and then the strength as well as the KLC1 serum level. So this is the best evidence saying that have to be followed with warm-up exercise and then followed by a resistance exercise program, and then cool down exercise for until 10 to 15 minutes, and followed with an aerobic kind of exercise program like walking and exercise program that has to be followed to get off your best benefit of the program, exercise program. And this is the another the supportive studies showing here mild intensity resistance training like half squat and calf rise, as the half squat and calf rise is the best intensity resistance training program by their own body weight, by utilizing for that to make it out to go for your half squat and calf rise. It will be best way to getting the benefit of decreasing your the insulin response in adults with type 2 diabetes. And prolonged sitting, interrupted sitting, that will be the one of the another kind that will be helpful for what you're supposed to be do. Interrupted prolonged sitting with a brief session of light intensity walking and simple resistance activity, which will be helpful to reduce of your insulin response in the type 2 diabetic. And another recent study, June 21, it shows that the type 1 diabetes, they have to participate in 60 minutes of daily to moderate to vigorous activity for an 66 to 17 years of age group. There will be improve of the glucose control and decrease of the hyperglycemic level. So that is the recent study. It shows this here. And all the time, why should we sit less? Whenever you will be under work, you should, all the time, you should not be prolong your sitting time. You have to be interrupted by doing of your 3 minutes of, this is a study actually, it's a study showing that 3-minute bout of the simple resistance exercises and light intensity walking, that will be helpful for reducing all the cardiometabolic risk markers in the type 2 diabetic. So what is the thing supposed to be do for a light intensity walking and simple resistance exercises? So simple resistance exercises, you can just go through with this point of all these 4, like a half squat and then heel rise and then gluteal contraction, and then for a knee rise, it will be the best benefit for getting your risk can be easily be reduced with the type 2 diabetic. And foot care, this is about the foot care actually. So we have to be a bit rushed. Foot care supposed to be when they participate in the exercise program, they should not be walk with a barefoot, either indoor or outdoor, because if it is get off any wound or anything, it makes to get delay in healing as well. So they have to be very careful. They have to wear a proper shoes, and then you have to check that what are the things supposed to be do. They have to regularly check the feet, and regularly they have to use the proper shoes, comfortable shoes, and then I can say they should not participate in the exercise program in the hot and cold weather, and all the time have to be checked with the podiatrist to right way to see that any changes in the feet, anything wrong if it is. Then foot care, foot facts. What are the foot facts? According to the Canadian Association of Wound Care, they prescribe that how to make, how to get the shoe, or what is the way supposed to be. Find out the shoe when it go for doing with the, when they participate in the activity, or when they want to wear and participate in the activity. The length, and then width as well as the depth of the shoe properly have to be checked, whether it will be fit in a proper in your foot in a proper way, that you have to see, and whether it will be fits well, and it have to be checked whether it will be a good absorption which is there, and then how the heel must be have to be checked, how the heel absorption it is there, that have to be see a lot of information is there how to choose for the shoe, mainly for a diabetic as well as for the normal individual. When you purchase or when you buy, you have to check about all these things to avoid of any any the ulcer over the side of the toe or the little toe, so that or in the heel. So you have to check about this. And I'm just showing that light activity and moderate different activities here. Why? Because all these things are very important when you prescribe physical activity for a diabetic with the diabetic complication, with the diabetic with a lot of complication. So light activities, you can choose walking slowly is the best activity. Moderate activity, you can see that brisk walking. So I'm just showing only one example over here. Like example, I can take like walking. The slow walking comes under the category of light activities. The brisk walking comes under the category of moderate activity. Jogging or running comes under the category of your vigorous activity. It can be said that you have to be go through with running and walking, intermittent kind of thing. You have to make it out to get avoid of exertion. And running experts saying that every time you have to make to change of your shoes every 300 to 400 miles. That is the way, because otherwise the heel or the sole, which is not be perfect fit for your foot to be perform of your physical activity. And these are the very vigorous activity. This is not at all prescribed for a diabetic person. This is not advisable to go for a very vigorous activity to participate. And I say that example of circuit training and go through with them spinning classes, all those things. Okay, this is the strengthen activity, or the strength, how to make it out the strength of the muscles. Nothing to be worried. In your home, you can make it out by your own body weight. You can make it to do of all these program, own body weight exercises. This is the best way. No need to go through and getting of all your instruments or equipments. So it will be the best way to do in your own body weight exercise program. See, all these things, these two like push-ups and pull-ups will be helpful for to make it out of your upper limb strengthening and triceps dips. And then this is the one where it can be make it to improve of your core muscle in sit-ups. And then the body weight squats is the one where it can be increase of your strength of your lower limb. And then this is the one where the back bridge will be helpful for to core strength of your core muscle. This is the another way, mountain climbers, it will be the best way to improve of your full body, workout of your full body as well. So other than that, you can use TheraBand exercises, and then Tai Chi is also one of the best way to improve your strength muscles. Okay, these are the exercise program for an the person with the diabetic with complications like heart disease and high blood pressure. If they have got, they should avoid of taking the strenuous activities. They must be go through with the moderate activity only, like walking and then stretching activities with a moderate limit. They must be participate.
Sorry, Dr. Ilyaraja,
Yeah.
can we please conclude?
I'll conclude. Okay. So these are the activities go through with osteoporosis, peripheral vascular disease, retinopathy, autonomic neuropathy. All these are the different the complication along with the people. They have to be go through with the different activities to participate. Okay, so light, moderate, and vigorous activity has to be classified according to the capacity of a person. You have to prescribe the exercise program. And the last point, I can mention only one few point about can stress trigger type 2 diabetes? Yes, this is the one where it will be get off your type 2 diabetes as well. Stress. It makes to increase of your cortisol and affects of your insulin resistance, makes to increase of your blood sugar level, makes to get off your diabetic, type 2 diabetic. This is the yoga, and then progressive muscle relaxation and diaphragmatic breathing is the best way to reduce of your stress level as well. These are the digital stream which is going to be use it if the person has got diabetic. You can use it all the newest technologies, wearable technology. The lot of applications are there like Tactile Health and then AcuCheck are the best top scoring app mobile app rating scale. According to that, it shows that it be giving of your best benefit of getting your physical activity to identify nutrition, blood glucose testing, medication, health feedback, and education. So all these things can be easily be identified by using of this mobile app rating scale. Mobile app Tactile Health and AcuCheck, according to the mobile app for the management of diabetes, according to the University of Florida, studying that. Okay, so that's what I don't have much more time. So these are the things. Nutritional one, I can be say that everyone can. I mean, diabetic, even for the diabetic people, you can eat same as food as a person with without a diabetic, but have to be in a balanced way. So this is the one. The meal plan you can be refer the diabetes meal plan for diabetes Malaysia. You can refer and you can get that idea how far the nutrition will be helpful for to make it out to control your diabetic. And don't excuse for not to participate in your exercise program. You have to make sure that all have to be participate in exercise a minimum of 30 minutes per day, that to avoid of all the further complication as well. This is the one, and you have to make sure you have to guidance of your doctor and other qualified health personnel before going to participate in any kind of exercise program is the better way. And thank you very much. Taken a few extra minutes. Thank you for listening.
Thank you very much, Dr. Learaja, for an amazing session. I'm sure our participants have gained a lot of information from this session. Due to lack of time, we will be doing our question and answer session after the end of the session of the next speaker.
Okay,
So
thank you.
if you have any questions, please type in the chat box for Dr. Learaja. He will be addressing to the questions later. Thank you, Dr. Learaja. Thank you for a great session, and it was a pleasure having you with us. Thank you.
Thank you.
Now, we move on to the third topic of our webinar. So in this session, we gladly welcome Associate Prof. Rajeswari Asokan, who will be speaking on the topic of physiotherapy management of neonates. Let me share a biography of Prof. Rajeswari. Associate Prof. Rajeswari has completed her Masters in Physiotherapy in the area of Pediatric Neurology in the Tamil Nadu Dr. MGR Medical University in the year 2004. She is currently working in the Faculty of Physiotherapy of Sri Ramachandra Institute of Higher Education and Research. She is also pursuing her PhD in early intervention for preterm and low birth weight infants. Her area of research includes pediatric neurological physiotherapy, early intervention, and parental education. Let us give a good round of applause to Associate Professor Rajeswari. Welcome, Prof.
Thank you for the introduction. And I thank the Department of Physiotherapy, University Tunku Abdul Rahman for organizing this webinar and giving me an opportunity to be a part of this. You will be sharing the screen?
Ma'am, if you have the presentation, you can share your screen.
Okay. No, I'm getting it as has disabled the participant screen share.
Okay. All right. We just attend this one.
Yeah. Shall I start?
Yes, please.
Okay, today we are going to discuss about physiotherapy management of neonates, especially in the high risk group. So first of all, we will look into whom we call it a neonate. So any baby who is around 4 weeks of age or younger than that, we call them as neonates. And this period is very critical because many neurological changes are very rapid in this period. So if you look into the feeding patterns and the bonding between the parent and the infant, all these things get established. And many birth defects or any other congenital defects are first noticed in this period. And there is increased chances for infections also. So if you look into the nervous system in this period, so it is the nervous system will be highly plastic, and the intrauterine environment for the fetus would have given a very optimal environment for the maturation of the synapses and the myelination, especially from the period of 14 weeks of gestation, and it continues till the 35 to 40 weeks. And the other process like gyrification, and also that is the formation of gyrus and sulci, and the surface area of the cortical gray matter, everything will increase. So this will enable the nervous system to process the information more. So when you see if this process of normal development is disturbed, that is if in the infants who are born before 40 weeks of gestation, and further when they are in the environment like NICU, so due to the early harmful exposure to lot amount of light, increased light or sound, etc. So that might again have an impact over the developing brain. So here 21% of the infants are born before 32 weeks of gestation will have a very severe white matter injury. So furthermore, if there is any reduction in the size of corpus callosum, and again it will may predispose the infant to the development of cerebral palsy like symptoms in the later ages. So now we look into who is called as a high-risk infant. So regardless of their gestational age or birth weight, so if they have an increased chance of morbidity or mortality because of their circumstances or conditions, because they are deviated from their normal course of events. That is, they are unable to adjust to the extrauterine environment since they are exposed to it very early. So the high-risk neonate can have these characteristics like birth weight less than 1,500 grams, gestational age below 32 weeks, or who may require ventilation assistance, and Apgar score of around 3/10 or 5/10 within this range, or if they are suffering from conditions like neonatal seizures, sepsis, apnea, infection, all those things. So we can say a high-risk infant will require more than standard process of monitoring, and when compared with a healthy term newborn. So here, depending upon the risk categorization, we have to give them continuous monitoring with specialized tests and therapy protocols. So the role of neonatal physiotherapists in NICU will be to not as it is not a rehabilitative one, but we'll be working for improving their like a preventive aspect. Okay, so it trains the baby's movements and developmental behaviors, that is in order to prevent future problems and to offer a comfort zone to the infant who is in a very difficult environment. So again, we'll be responsible for nurturing the brain growth. And yes, genes have a great role, but the brain development also depends upon the interaction between the genes and the environmental experiences. So we are going to give a proper graduated early sensory information and motor experiences, so which will help in maintaining the normal architecture of the brain. Okay. So although each infant has a unique brain maturation levels, so even if we give them a same extrauterine environment or caregiving, it may have a different effect over the brain structure. So every therapy should be unique for the neonate. So coming to the neonatal therapy examination and their intervention strategies, so that should be customized and it should be carefully modulated and it should be in phase, so that we are able to protect the architecture and the maturation of the infant's brain. Okay. So in an NICU, you can see the preterm babies or any other high-risk babies or with immature organ system, and they are understimulated or overstimulated because of the NICU environment, or that you can say that is inappropriate pattern of stimulation. And immature distance receptors, example, you can say hearing, vision, and mature tactile and vestibular pathways may be understimulated, and there may be less parental involvement. So these are the this is the way how the infant is maybe connected with different things like ventilator, feeding tubes, etc. So in an NICU, we should follow an appropriate approach which modifies the environment, like noise, light, positioning, positive touch, and pain management. So we should try to provide a normal stimulus to the or experience to the infant. So in an NICU, we should not follow a routine care. So we should go along with the signals which are given by the infant in the therapy point of. So coming to the neonatal neurological examination, it varies basically by gestational age and the state of the infant. And so the examination will be a changing and a dynamic process. So we already saw about this Apgar score in the high-risk infant characteristic. So this scale gives us a grading about the heart rate, respiratory rate, and the reflex stimulation and the color of the baby, depending upon these criteria. So the assessment of gestational age will be the first thing what we will be looking into this examination. So it is usually established by last menstrual period or from the first trimester ultrasound scan. And we can use Ballard scoring system, which will be helping us to monitor the neuromuscular and the physical maturity. So in the neuromuscular maturity component, we will be looking into like the posture, the square window, arm recoiling, popliteal angles, scarf sign, and heel to ear. All these things will be measured and the gradings will be given accordingly. And this scale tells us about the physical maturity component and the components which are being looked into: the skin and groove, the plantar surface, breast, ear or eye, genitals, both with the male. As I've already told you, depending upon the age, the changes will occur in the the findings will be different in the neonatal neurological examination. So you can see in the table, that is the changes which we can look into around 28 weeks, 32 weeks, 34, 36, and 40. So here, regarding the head circumference, you can see the changes are around like 26, 29, 31, 33, 34, etc. And the level of consciousness, alertness. So in the initial stages, the majority of the time will be in sleep. Then you can see it is gradually progressed to sleep-wake cycles, and maybe later, and more often, it starts responding to external stimuli. And cranial nerves also could be looked into, like cranial 1, 2, 4, 6, 8, etc. So gradually they start responding to smell and blink, startle, or other responses get started to loud sounds, etc. And as far as the motor is concerned, the first there will be flexion of arm, flexion or extension of leg, then later they may go into the flexor. And reflexes, we can look into various neonatal reflexes like Moro, rooting, sucking, etc. So we have, and also gradually we can look into the asymmetrical tonic neck reflex, etc. Then later by the writing and equilibrium reactions. First thing what we have to see is the observation part. So all infants initially they might have an increased physiological flexion, that is symmetrical posture. When you place them on back, they may roll to side with flexion of both arms and legs. But in preterm infants, the extremities will be in more extended position due to the lack of flexor bias. So full extension of legs, if it is there, then it may suggest there is an increase in muscle tone. If you have a frog-like appearance, then it might suggest hypotonia. But infant which were born out of breech presentation also will be in this position, that is with legs fully extended, especially in the newborn period. So in the prone position, you may look, the head might be turned to one side for breathing and limbs are flexed and pelvis might be raised with knees drawn higher and under abdomen. And note for any arching of the back or increased extension. And if you go for ventral suspension, the gravity may be stronger than the extensor. And we have to look in for either any of these decorticate or decerebrate posturing or opistonus, which might be like arched back, which indicates hypertonia. And we have also to note the asymmetry of posture, which might indicate hemiplegia or fracture clavicle or humerus, or it might also denote brachial plexus injury. And coming to the cry, we should recognize whether there is any high-pitched cry which indicates an abnormal baby, and movements, whether they are spontaneous or provoked. Spontaneous movements might be like tremors, twitching, and sudden shock of movements without any apparent stimuli given. And we have to note for asymmetry of movement, and the wakefulness and sleep cycle should be checked. So abnormal babies commonly sleep for excessive periods. So coming for vision, we can look in for nystagmus or opacity, and also to look for inequality in pupils or any fixed squint. And screening tests also might be indicated for checking their ability to hear. And head circumference. So the growth of the head will depend upon the cranial contents. So if there is if any small head seen, then it could be leading to conditions like mental subnormality or craniostenosis. Big head might indicate hydrocephalus, or it could be subdural effusion. So this table tells us about the head circumference in inches and centimeter. So at birth, maybe around 13.7 inches and 34.8 centimeters. Then next important component will be the assessment of primitive reflexes. So these are survival reflexes, which will be occurring in first few weeks of gestation itself, and which are automatic stereotype movements, and which are directed by the very primitive part of the immature brain. Okay, so these will be short-lived, and these will be replaced by more sophisticated structures when your higher areas of the brain take over the control. So if there will be a specific period of time for each primitive reflex. So within that time, if it is present, it is okay. If it is beyond that time, if it is still positive, then it gives us a considered aberrant and evidence of an immaturity if they are present beyond their time. Few examples we have already seen, like Moro, startle, sucking reflex, rooting, placing response, walking reflexes could be evaluated. Okay, we can look into the deep tendon reflexes along with that, and we can also do the component of estimation of muscle tone, where we can look into both the passive and the active tone. So for assessing the passive tone, we will be using Amiel-Tyson angles, and this passive tone will increase in the cordocephalic fashion from 28 to 40 weeks of gestation, which will result in a physiological hypertonia. So this table tells us about the angles what we will be measuring. So any adductor angle, heel to ear, popliteal angle, ankle dorsiflexion, and scarf sign. So Within 3 months, these are the values what we can get, around 40 to 80, 80 to 100, and 60 to 70. Regarding the scar sign, the elbow does not cross the midline. So progressively, we can measure the values are given for the respective months. So these angles will be measured with the help of goniometer, which is indicated in the picture. So using a neonatal neurological assessment scale, we can look into these 3 main components. That is the integrity of the nervous system and the way to calculate the gestational age and how to describe a newborn behavior. So these are the other frequently used scales for assessing or examining a neonate. That is the clinical assessment scale, assessment of gestational age by Dubowitz, a neurological examination of full-term infant, a neonatal behavioral assessment scale by Breselton, a neurological assessment of preterm and full-term normal infant using again the Dubowitz and Untitled. The other commonly used scale is Hammersmith Neonatal Neurological Examination Scale. So after the examination, we may have these abnormal signs in a neonate if it falls under a high risk group. That is shrilled or high pitched cry, and the child may be irritable or hyper alertness might be there, and the position may be like pit frog position in supine, or it might have a hopelessness, and little spontaneous movements could be seen, or it could be asymmetrical also, and tremors, apneic attacks, and convulsions, everything could be an associated problem. And as far as the head size is concerned, it could be large or small with bulging anterofrontally. And the eyes, where there might be nystagmus, pupils might be flexed and dilated with sunset sign, especially in case of hydrocephalus. And here, there may be poor orientation to sound. And the reflexes could be increased, absent, or asymmetrical with abnormal primitive reflexes like Moro and poor sucking and feeding. So later, there might be strong grasp, Moro, and ATNR. So the tone could fall in any of these categories like hypotonia, hypertonia, asymmetry, excessive extensor tone, and which may predispose to later gross development delays. So coming to the therapy part, early stimulation, or what we call it as is a intervention what we are going to apply to this high infant group. So it is a way of stimulating child senses which allows the brain to develop more rapidly and in an extensive manner. So this is indicated for all the babies who are at high risk of developmental delay and who may require periodic developmental cases so that they can attain complete motor, social, cognitive, and language development. So why it is so important, why it has given us, all parents will feel that their infant should be developing into their maximum calls at that time where your symptoms and other things would have been reached their high state. And the parents are adapting small family norms, and every child is precious and they want a high degree of quality in their life. So we will start with each kind of stimulation, what we can apply to a neonate so that they can we can pave the way for normal development. So coming to the first kind of stimulation, that is we use tactile stimulation. So as far as the fetus, that is in the womb and during the gestational period, it receives rich tactile experiences as it is continuously bathed in the amniotic fluid. But when the infant is in the ICU, this kind of stimulus will be absent, and due to and there will be multiple handling by the various health professionals other than the mother for routine medical and nursing procedures. So which may have a negative effect over the infant. So these multiple handling and may cause hypoxia, bradycardia, sleep disturbances, increased intracranial pressure, and behavioral agitations. So we require supplemental tactile stimulation, ensuring that along with that we should give only minimal and gentle handling. So We can prescribe gentle touch and stroking maneuvers, which may improve weight gain, sleep-wake pattern, and which may also improve thermoregulation. So here we can frequently change the child's position. So we can put the child on his sides, on his back, and on his tummy, etc. And we can use different surfaces like soft mattress, foam rubber mat, and on soft cloths or mother's lap, etc. Along with that, gentle touch and stroking maneuvers can be applied. And the way we hold the baby while feeding also will add to the tactile stimulation what we are doing. So the next kind of stimulation will be through swaddling. During the non-contact period of the infant and mother in the NICU, so the infant will be deprived of again the tactile stimulation. So this can be overcome by this procedure called swaddling. You can see in the picture, wrapping the child with sheets of cloths or blanket, and which can be done prior to the positioning on a cradle board. So this is also referred to as tucking, containment, binding, or bundling. And these swaddled infants, the advantage of this is they will have longer sleep periods and they are less aroused, and this will improve their physiological, that is the lowers their heart rate and behavioral states, that is it calms their infants, induces and prolongs sleep, and fewer startled responses. And it also reduces the pain and also prevents the hypothermia. And it also improves the neuromuscular development and motor organization. Coming to the negative effects of this procedure, it includes the respiratory infections because of tightened swaddling and increased risk of sudden infant death syndrome when swaddled with prone positioning. And it may also increase the risk of hip dysplasia if it is maintained in extension and adduction. And increased risk of hyperthermia also might be there when misapplied, and decreased postnatal weight because of the early separation from the mother. And longer sleep and less nursing requirements and delayed rest. The next type of early stimulation could be like gentle human touch and massage. So under that we have infant massage therapy, which involves gentle touch or stroking or rubbing the infant with hand using light or moderate pressure. And several studies have reported that the increased benefits of massage, which could be done with or without kinesthetic stimulation. So the advantage of this is it improves weight gain, improves physiological and behavioral states, decreased stress behaviors, improves pain alleviation, reduce postnatal complication, reduces the hospital stay duration, improves the performance and developmental scores. But concerning evidence, there is a little lag. The next component of this is gentle human touch, which involves placing one hand over the infant's head and other over the lower back, extending to the buttock for 10 to 20 minutes of duration. It has no adverse effect on mean heart rate or oxygen saturation levels, but however, that touch has shown that it could result in increased respiratory regularity and improved sleep cycles. That is decreased active sleep and increased quiet sleep, and motor activity and behavioral distress during the periods of gentle touch. And coming to the next thing, pain. There is a myth that because of reduced development of pain pathways, the pain experienced by the. So as far as pain management is concerned, we can use kangaroo mother care, non-nutritive sucking, and swaddling or facilitated tucking interventions, rocking or holding for reduction in both pain reactivity and for immediate pain-related regulation that will influence the position or neurobehavioral states. So the other ways we can use sensorial saturation, multi-sensorial stimulation techniques, which consists of tactile, vestibular, gustative, olfactory, auditory, and visual stimuli. Our next kind of stimulation will be kinesthetic and proprioceptive stimulation, where we may use range of motion activities. if you see, the spontaneous movements of extremities are very much will be reduced in a preterm or very low birth weight infants because of increased period of time in a swaddling position or minimal handling requirement of infants in the ICU, and also they will be having reduced physical activity. So these range of motion activities and the other gentle movements or longitudinal compression of the extremities, that is by passive weight bearing, etc., will improve the weight gain, bone width, and bone mineral density. So the similar observations are reported in evidence that circulating leptin levels, which are correlated with birth weight, will also increase the bone mineralization. So the physical activity programs will might promote short-term weight gain, bone mineralization, but for long-term effects, there is very less evidence for that. Coming to infant positioning, in preterm infants will have hypotonia. And they will also be having difficulty in using the extremities in midline and for sustaining the symmetrical flexion, posture, and movements. So during in an ICU, such infants should be positioned in a swaddled position during their sleep cycles, that is in supine, and also in prone or in sideline position for a brief period when they are alert or in a awakened state. So infants who were positioned in prone are reported to have attained more better motor milestones much earlier when compared with infants positioned in supine position. So prone position may also prevent positional deformities, which may have an implication over the neurodevelopmental behavior. So the infants who are positioned in supine, prone, and sideline should be maintained in a tucked position, tucked flexion, with more spontaneous midline activities and symmetrical anti-gravity positions similar to that of the full-term infants. So this picture will tell you how to position the infant and sideline, both in the right and the left side, and then supine position and the prone position. And the nesting recommendations. This will provide the boundaries around the infant, so that will maintain and encourage flexion, so that also allowing the room for extension activities. This is why, because in a womb there is a containment given to the infant, so that which even if it kicks against the uterine wall, and it will again stimulate the flexion. So here this will provide covering, and light swaddling also will be added to comfort the infant. You can use soft mattress to support the infant's head and reposition frequently to avoid the flattening of the head. So you can utilize both prone and sideline position also whenever possible in this nesting condition. Coming to the next kind of stimulation, that is the olfactory and gustatory stimulation. So in the gestational period inside the uterus, amniotic fluid will be swallowed continuously by the fetus, which would have facilitated early chemosensory experiences. But in the postnatal period after birth, these chemosensory experiences combined with sucking reflex activity will facilitate nutrition seeking behavior and also the tactile needs of the infant, so that they feel relaxed and secured with the mother, and they also start to explore the environment around them. So preterm infants, that is who are born before 36 weeks, will not be able to coordinate sucking and swallowing and breathing, and so they will be depending upon alternative feeding methods. These feeding methods will negatively deprive the preterm infant from normal sensory experiences, which may impact the taste and smell. So for this we can use...
Sorry to interrupt, Prof.
Yes.
The time is up.
Yeah, I'll just shut.
Okay.
We can use non-nutritive sucking procedures, oromotor stimulation techniques, nutritive sucking, or breastfeeding. The next kind of stimulation is vestibular, so which have a positive effect on arousal level, visual explorative behavior, motor development, and reflex integration. So you can use techniques like rocking, etc. Next kind of stimulation which can be utilized is auditory stimulation, that is the fetal response to maternal voice is indicated as early by 27 weeks of gestation in the womb itself. So, but in an ICU you can see the noise levels will become higher when compared to the intrauterine environment. So the sound limit of around 50 decibels, that is which may pave the way for normal development and maintenance, which should be maintained. So the parental voice at the bedside is going to help the infant to overcome this issue. The next kind of stimulation is visual stimulation. So this is the last among all the sensory modalities to develop, and the visual pathway will get matured only around 39 to 40 weeks. So visual experience for healthy visual development will require ambient light, that is not a direct light, and after 2 to 3 months with specific colors. Okay, so we can expose the child to rhythmic low-level ambient light for entertainment of circadian rhythm, prevention of eyes from direct light exposure, and facilitation of sleep cycles. So for this, we can utilize flashcards, which is shown in the figure here, for visual stimulation, and hang brightly colored cloths like red, orange, or fluorescent around the child. And we can place a high contrast image at a distance of 8 inches for 5 to 10 minutes. Or you can hold a mirror 7 to 8 inches away. And the main care what we can give as a part of early stimulation is gangrene mother care. Here this includes, you can see in the picture, intermittent prolonged skin-to-skin contact of the infant with the mother with exclusive breastfeeding. So it provides tactile stimulation to the infant by having prolonged skin-to-skin contact with the mother, kinesthetic and proprioceptive stimulation by the swaddled position of the infant, olfactory and gustatory stimulation by breastfeeding, oromotor stimulation by sucking of the nipple, and auditory stimulation by the maternal voice. So these will improve neurobehavioral organization and prevents hypothermia and increases the bonding between the mother and the infant. So as far as early stimulation is concerned, mother will be the main part and she will be the sole contributor, main contributor. So the parental attitude will have a great influence over early stimulation. So we have to involve the parents as a main decision makers in the early stimulation protocol. And they are the main ones who will detect the clues from the child for customizing this early stimulation. So they may require appropriate counseling, and we have to educate them about the positioning and various therapeutic handling techniques in order to optimize the body alignment and facilitate various movements. And for them, we have to train them in visual, auditory, tactile, kinesthetic, or vestibular stimulation techniques, so that it will pave way for the infant to explore the environment, thereby resulting in a more normal motor development. Okay. And we have to teach them also how to monitor the normal motor development in an age-appropriate manner. So this picture will just tell you how to, can be given to the parent to say how to pick up a newborn baby, and how to hold a baby in various positions, and how to take precautions as far as shoulder is concerned, how to carry, etc.
Thank you very much, Prof. Rajeshwari, for the amazing session. And I hope our participants have enjoyed this wonderful and informative session. So now Prof. Rajeshwari will be answering some of the questions that has been sent to us during the session. So here's the first question. Prof. Rajesh?
Yes.
All right. So here's the first question. According to current advanced medical technology evidence, what is the survival rate for neonates born before 40 weeks?
Okay. Currently, we have around 80 percentage around in any.
Sorry, Prof, you can switch on your camera if possible.
Is it switched off?
Yeah, it's off.
Switched off. You can see me
No, unable to see you.
now.
Still not able to see.
Actually, Ms. Swapnila, we can see her. Prof. Rajeswari, we can see her. There could be a bit of lagging on Ms. Swapnila's side.
Considering the advancements in the neonatal care, the survival rates have increased to many folds. Okay, maybe around 80 percentage nowadays because of this in advancement in care.
Okay, so it's quite increased now. So neonates have better chances of survival nowadays.
Also, the problems which we have along with their survival rates means we have to give more advanced care to pave way for normal motor development.
All right. Okay. Thank you. So the next question is, what kind of physiotherapy care can be given to premature babies?
That is what we are trying to change here is we are trying to provide a similar environment which was like an intrauterine similar environment. So we are trying to connect the baby with the intrauterine environment to the extrauterine. So with the help of similar sensory experiences which the child would have experienced in the uterus. So again, it should be in a customized manner which each child will be responding in a different manner to different sensory stimuli. So we, based on the trial and how they respond to each sensory stimuli, we have to design our protocol. That is the sensory stimulations. I cannot hear you.
Okay, we have yet another question for you.
Yes.
Which exercises can be given to neonates with neurological impairments?
In the first few weeks, that is neonate means in the first 4 weeks, right? It might not be much evident to deduct very precisely. Later, depending upon what kind of impairments they have, that is what kind of gross developmental delays they are having, like the tonal abnormalities, the sensory things, we can go for early intervention techniques which will specifically like facilitating or inhibiting their responses in the later stage. So that is basically based on the type of neurological impairment they are going to suffer. That is cognitive, like motor, sensory, things like that.
Okay, Prof. We have a next question. Can you tell something about the scarf sign?
Scarf sign is how the elbow crosses the midline. Okay, so initially, if when they are in increased hypotonic, physiological hypotonicity is increased, they might cross it easier. The later, when the tone increases, again it takes time for crossing the midline, and in hypertonia also they might not. That is basically how the elbow crosses the midline of the body.
Okay, all right. So thank you, Prof. Rajeswari, for answering those questions and for a great session. It was a pleasure having you with us. Thank you very much.
Also thank the Department of Physiotherapy for providing an opportunity to be a part of this webinar. Thank you.
Thank you very much. Okay. So a gentle reminder again to fill up the feedback forms with your name and email addresses so that the certificates can be sent to you accordingly. If you do not receive your certs, please write to us, physiodepartment@utah.edu.my within 3 days. Thank you. The contact is there, is in the chat box. You can take the details from there. So now it's time to take the picture. I request all the participants to switch on their cameras so that we can have a group photo for our webinar. So kindly switch on your cameras.
Ms. Swapnila, we will do the question and answer for Dr. Ilya Raja.
So shall we continue the question answers now, ma'am?
Just a few questions for Dr. I before the photo taking. Thank you.
Okay. Okay. So, participants, please, please wait for a while. We will just finish our question and answer session with Dr. Leah Raja, and later we will do the picture picture taking. All right. So, Dr. Leah Raja, we have few questions for you. So, the first question is from a participant, says that I'm facing obesity problem, but I have no diabetes. Is there any reason for this situation? All right. So, Dr. Leraja, the first question for you is from our participant. I'm facing obesity problem, but I have no diabetes. Is there
Okay.
any reason for this situation?
Okay. Obesity, actually, obesity, they don't have the diabetes, is it? Okay. So I can say one thing. Obesity is the one where more have a risk of 80 to 85% have got the more risk to develop as like a type 2 diabetes in the later stage. So better to avoid of getting the type 2 diabetic or the later time of development of the type 2 diabetic. Better they can participate in a heavy works of like vigorous activity. They can participate and do of reducing the weight to be controlled in the normal range of BMI. If they get to be attained, that will be the best way to prevent and avoid of the complication which is going to be occur in the future as well. So weight loss is the best way to control and prevent of getting the type 2 diabetics. So that is the best thing I can say. So even though they don't have any diabetics, that is a good one. But at the same time, let them do and work out for more time to participate in a vigorous activity. By the way, they can prevent of the heart problems related with the heart problem, because obesity is more risk factor for getting your heart problems as well, and later part in the future time. So that will be better. They can participate in the vigorous activity, doing of your participating in aerobic kind of activity. Like mainly it will be best way to say aerobic kind of activity is best way to reduce of the complication, cardiovascular complications. So better than to participate in the aerobic activity. It will be helpful for to reduce the type 2 in the future, as well as all the other heart related problems.
Okay. Thanks, doctor. The next question is, does intermittent fasting help in curing diabetes?
Yeah, intermittent fasting, of course, some of the evidence showing that there will be some difference in the, the glycemic control. But the thing is, they have to be very carefully, they have to identify the safety measures, because when they works out or doing in the physical activity to participate, it might be lead to maybe after fasting or after participating in the physical activity, the blood sugar level may be going to be get low, or it may be lead to get off your hyperglycemic. So that is the one very keen to be checked after fasting. So it may be lower the blood sugar. They may not know that after fasting the blood sugar levels is low or high. So they have to be glycemic all the time. They have to be monitored, and according to that they have to work out. So there's some evidence it's showing that maybe this is other way they can say that it's due to weight loss. That is one of the reasons they said it is a weight loss. Is occurred due to intermittent fasting and getting some evidence to make up glycemic control. But anyway, still the research is going on to get up your long-term effect. So better to avoid of be fasting. Either they might be take off limit their meal. By the way, they can limit their meal with a balanced diet. That will be helpful for to make to be avoid of the low sugar level complications like hypoglycemic activity. That's the way.
Yeah, because intermittent fasting is nowadays is a trend. Many of the youngsters, they are following this intermittent fasting, and then they are
So instead of taking the fasting, better they can have light meal. Light meal, that is the better way to avoid of getting your hyperglycemia. That is what they used to get the lightheadedness, the dizzy, all they used to get it out, and feeling very tired. So instead of making it full your stomach, you can take a the light meal. That will be better way to avoid of getting the for the more day drowsiness or whatever. So that is the thing I can say. Yes.
We have one more last question, sir. That is, how to increase the metabolism?
Okay, the increase the metabolism. On sudden, you want to increase the metabolism, you can consume, the protein-rich diet can be beneficial to get increase of the metabolism. And long term, you want to make it out, you have to participate in the aerobic activity. Again, I can say that walking, swimming, running, cycling, all these kind of activity will be best to go for to make it out to maintain your metabolism and increase of your metabolism as well. So that is the one way. It will be very helpful. Yeah, the one I can say.
Okay, thank you, Dr. Raja, for answering those questions and for a great session. It was a pleasure having you with us. Thank you very much.
Thank you very much. Thank you for the team, everyone.
So we have come to the end of our webinar. Thank you one and all who participated in this webinar and practical demonstration sessions. I hope that we have been successful in bringing what you were looking for. Please feel free to express your views, comments, and compliments in the chat box. See you again in our next webinar series. Till then, take care and stay safe.